Okay, so let's change gears now. We've spoken lots about rhythms, and now we're just going to talk about myocardial infarctions and myocardial ischemia. Okay, so an infarction means myocardial cell death. Ischemia means reduced oxygen and hypoxia at the cellular level of the myocardium just hasn't died yet. Okay, which is good because sometimes we can reverse ischemia. Okay, but myocardial infarction, once those myocardial cells are dead, they're not replaceable. Okay, so let's look at some changes that we see in two types of heart attacks, a STEMI and a non-STEMI. Remember, if you've had a heart attack, i.e. a myocardial infarction, by definition, you're going to have released cardiac enzymes into the bloodstream. So you're going to have a positive troponin, whether it's an NSTEMI or a STEMI. So how do we categorize STEMIs and NSTEMIs? The ECG, okay? But knowing that you typically have a positive troponin in a heart attack, unless it's really, really early in the onset and someone presents with a heart attack, and the troponin hasn't had time to rise in the serum, which is usually 2 to 3 hours. So if they're really, really early, we may see ECG changes and the troponin just hasn't had time to go up yet. Okay, so let's look at some ECG changes. So one of the first changes to occur is these huge, what we call hypertrophic T waves. They're much larger than the QRS. Okay, and they're one of the first signs of a STEMI forming. Okay, these huge T waves. So if you look at the bottom rhythm strip there, look at that T wave. Ignore where the arrows are, but just look at the T wave. Look how huge it is. Okay, that's a hypertrophic T wave, and that's one of the first signs of that a STEMI is going to be coming. Okay, so number two, a STEMI, ST elevation MI. I mentioned this segment called the ST segment at the start of this module, and that's where we look. Okay, so again, if you look at the lower rhythm strip there, you'll see that that segment, the ST segment, that goes from the S portion of the QRS to the T wave is elevated. It's way above that baseline that's between the T wave and the P wave. So that's ST elevation. So on this rhythm strip, we actually have both signs on an ECG of a STEMI. We have hypertrophic T wave and we have ST elevation. Okay, and this usually indicates a complete occlusion of a coronary artery that's feeding a portion of the heart, and it's going to result in a full thickness myocardial infarction, meaning from the outer muscle to the inner muscle of the myocardium, it's going to be a full thickness heart attack, what we call a transmural heart attack, right through the muscle. Okay. Okay, so let's talk about an NSTEMI. So an NSTEMI is where there's critical occlusion of a coronary artery, but there's still a bit of blood flow, but definitely some of the heart has still died. Okay, there's been a rise in troponin, just like in a STEMI. And we see some slightly different changes on the ECG with an NSTEMI. Typically, we look for ST segment depression. So top left, there's ST segment depression, and that could definitely be with an NSTEMI. How are we going to decide if it's an NSTEMI? Serum troponin. Okay. The other changes that we can see with an NSTEMI is T wave inversion, which is the top right. How do we decide if it's an NSTEMI? Serum troponin. If the serum troponin is negative, with both of those above signs, the ST depression and the T wave inversion, sometimes this can be an indication of ischemia to the area, and it hasn't quite died yet. So the coronary artery is really blocked, but there's just enough blood flow that the muscle hasn't died yet. So this can occur in ischemia, coronary artery ischemia to a segment of the heart. Okay, so what decides whether you have ischemia or an NSTEMI? Troponin. Okay. Okay, so we'll move on from here. So remember, a STEMI, complete occlusion of the coronary artery. NSTEMI, critical occlusion of the coronary artery. Still a heart attack, but it shows up often with ST depression and T wave inversion, compared to a STEMI, hypertrophic T waves, and ST elevation. Okay, so let's move on. We're going to talk a bit about CPR, and there's an excellent video that you should watch. It's only about 3 or 4 minutes. We're going to talk about cardioversion versus defibrillation now. We're going to briefly talk about pacemakers, and I know there's a chapter in your book on pacemakers. And we're going to talk about implantable cardioverters and slash defibrillator. Okay, so CPR, cardiopulmonary resuscitation. So when do we decide to do chest compressions, plus or minus breathing for the patient? Okay, so what are the indications? So absence of pulses. So no carotid pulse. Patient is obviously unresponsive. They have no blood pressure as well, right? And typically with that, you have absent breath sounds too. Okay, so when you have a cardiac arrest, you typically have absent pulses and absent breath sounds. So the purpose of chest compressions, because I'm going to mention chest compressions more because that's the more important aspect of CPR compared to the breathing. So the purpose is to maintain some circulation and also some degree of respiration. Okay, and why do we want to do that? To prevent cerebral anoxia, so lack of oxygen to the brain, leading to permanent brain damage, right? So, I mean, sometimes we get a pulse back on someone who has been down for 20 or 30 minutes, only to discover that yes, we have a blood pressure, yes, we have a pulse, but they're brain dead. Okay, so it's not always a positive outcome to get a pulse back if they don't have any neurological function. Okay. Okay, so when do we stop CPR? Well, when the patient's pronounced dead. Okay. And that may be after multiple attempts at defibrillation and CPR, epinephrine, maybe an antiarrhythmic thrown in, such as amiodarone or procainamide. So multiple sequences of CPR, defibrillate, add some epinephrine, add some amiodarone, and we get a return of spontaneous circulation. Okay, so if we suddenly feel a pulse, well, we'll stop the CPR. Okay. What are the complications? Well, definitely fractured ribs in older patients or younger, but in particular older patients, the ribs fracture. A rib can puncture the lung beneath it, leading to a pneumothorax. A rib could puncture the liver, which is on the right upper side of the abdomen. And the liver goes higher than you think when someone's lying down, right? So you could definitely lacerate the liver. You can get a lot of abdominal distension. Why? Well, if someone's doing the breathing, say with a bag valve mask, all of that air or oxygen is going into the stomach, and it could really distend their abdomen. Okay, so sometimes we'll put a nasogastric tube in to decompress the stomach. Okay, now in single rescue CPR, it's stressed to really concentrate on the compressions, so chest compressions. Okay, typically about 100 to 120 per minute, and to forego the breathing. Every time you take your hand off the chest to do breathing, the blood pressure is going to drop. So single rescue CPR, the focus is on CPR. Okay. Most of the time, the typical person doing CPR can only last about 2 to 3 minutes, right? They're doing 100 to 120 compressions per minute. It's exhausting. Okay, so usually we have a lineup of people and we change people out every 2 minutes. If there's more than one rescuer, then we give 2 or 3 breaths after every 30 compressions. Okay. Remember, if you're a single rescuer by yourself, every time you compress the chest and let it go, the chest recoils and they actually get a bit of air into their lungs. So in a way, they're still getting some air during the CPR because of the chest recoiling. Okay. All right, let's carry on. Okay, I'm not going to spend much time on this slide. Look at the video. It's worth it. That video is from the American Heart Association, and notice how they're focusing on CPR, the chest compression aspect. Okay, they're not highlighting the breathing very much for a single rescue CPR because they really want people to focus on the chest compressions. In fact, we know that some people are really deterred from doing CPR at all because they feel obliged to do the breathing and they don't want to do the breathing aspect. So that's why the focus has really gone to the chest for the compressions. So what's the procedure? Identify the patient is unresponsive. They're unresponsive because there's no pulse, there's no blood pressure. Call for help first if you're by yourself. Why? Because you're going to be exhausted in about 3 minutes. Okay. You can do pulse checks. So check for a pulse. Obviously, you have to take your hand off the chest to do that. Check for a carotid pulse. Check for any breathing. And if there's 2 people, it's 30 chest compressions for 2 rescue breaths. If you're by yourself, it's just chest compressions at 100 to 120 per minute. That's 2 compressions per second. Super fast. Okay. If it's noticed that the person's in an awkward position and their head's all flexed forward, you might want to just do a head tilt or a chin lift to get their airway nice and straight so that air is still going in when you release during CPR and the chest is recoiling. Okay. The delivery of 2 rescue breaths is when there's another rescuer. Okay. So now it used to be that we'd say, okay, do 30 chest compressions, do 2 breaths. Do 30 chest compressions, do 2 breaths. But we're going away from that if it's a single rescuer that's available. Okay. And then this just continues until they have return of spontaneous circulation, so they get a pulse back, or they're pronounced dead.